Good evening to all. At the outset, let me congratulate the REACT Asia Pacific team for having organized this webinar series on COVID-19. For those of you who are wondering about the strange Hanta virus update in the season of COVID-19, let me update you. In the third week of March, there were reports of a Hanta virus case from the Yunnan province of China. As always, there were rumors that we were going to see another pandemic of hantavirus infections. Before we answer the question, can hantavirus infections cause pandemics? I'd like to take you through my lecture, which deals with the structure of hantaviruses, infections, clinical picture, transmission, prevention, and treatment. It also includes research that has been done in India on hantavirus infections. History of hantavirus infections. Hantavirus infections first came to the attention of the Western world only in 1951, when there was an outbreak of hemorrhagic fever amongst UN troops who were stationed in Korea during the Korean War. The disease, which had a fatality rate of 15 to 20%, was named Korean hemorrhagic fever, later renamed as hemorrhagic fever with renal syndrome, HFRS, as we know it today. It was only 25 years later that Dr. Lee, a pioneer Hanta virologist, was able to discover an antigen in the lungs of a locally caught mouse, Apodemus agrarius. This antigen he saw reacted with the sero HFRS patients. He was able to cultivate this etiological agent in continuous cell lines, and in 1980 he gave it the name Hanta virus, as the mouse was caught along the banks of the Hanta River. By 1980, it was understood that there were a large number of serotypes which caused similar kind of clinical syndrome. They were all brought under a new genus, hantavirus. In 1993, there was an outbreak of an unexplained pulmonary disease in the Four Corners region of the US. The victims were primarily young, healthy adults, and the fatality rate was about 40%. This new pulmonary disease was initially named as hantavirus pulmonary syndrome, later renamed as hantavirus cardiopulmonary syndrome as we know it today. The etiological agent was described as a new hantavirus serotype Sin nombre virus being hosted by a local rodent, Peromyscus maniculatus. It was earlier believed that hantaviruses are exclusively rodent-borne viruses, and each serotype or species are hosted by specific rodent species. For example, Hanta virus is hosted by Apodemus agrarius. But later on, it was found that different kinds of mammals can host hantaviruses, which include shrews, insectivores, moths, and even bats. Also, it was discovered that multiple hantavirus serotypes can be carried by the same rodent species. Hantaviruses, they establish a persistent infection in the host but do not cause any disease. There is shedding of plenty of virus in the urine, saliva, and feces of the infected animal. There is a close bond between the host and the virus, so much so that they co-evolve together, and their phylogenetic trees look very similar. Viruses are broadly divided into Old World and New World hantaviruses. Old world hantaviruses are those which circulate in Asia. New world are those which were discovered after 1993, mainly known to circulate in the Americas. In this slide, I've highlighted a few important serotypes of hantavirus serotypes, which include Hantan virus, which is the prototype of all hantavirus species. Hantavirus disease is primarily a rural disease, with the exception of Sol virus. It is a hantavirus serotype which is carried or hosted by the rat, Rattus norvegicus. We know rats are worldwide in distribution. So Sol virus infections are seen in urban as well as rural areas. Another important hantavirus serotype I'd like to highlight is the Thailand virus, which causes very mild hemorrhagic fever with renal syndrome in South Asia, and it is hosted by what we call the bandicoots, Bandicota indica. This serotypes or species which are seen in the Americas are Sin nombre virus, Andes virus. Both of them cause severe hantavirus cardiopulmonary syndrome. Hantavirus structure. Hantaviruses have a negative sense tri-segmented genome as seen in the slide. The large L segment codes for the viral RNA-dependent RNA polymerase, RDRP. The medium M segment codes for a glycoprotein precursor that gets processed into two envelope glycoproteins, GN and GC, whereas the small S segment codes for a very important nucleocapsid protein. The hantavirus particle per se is spherical, about 80 to 120 nanometer in diameter. And as you can see in the slide, they contain 3 circular nucleocapsids. Each of the nucleocapsids have one of the RNA segments complexed with N and RDRP proteins, as depicted here. Now, the L protein codes for about 2,150 amino acids, the M protein for 1,140 amino acids, and the S segment codes for the N protein, which is about 430 amino acids. I would like to highlight the N protein here, as it is largely used in diagnostic assays for hantaviruses. N protein is produced in very large amounts and very early in infection. It is very antigenic, highly antigenic, elicits a very strong immune response. N protein can be used as targets for molecular assays too, as the amino terminus has 100 amino acids which are highly antigenic and greatly conserved between hantavirus species. As the slide shows, there is horizontal transmission of infection between members of the mammal or rodent species, and it occurs when they exhibit aggressive behavior, as in infighting, biting, or even during mating. But how do humans get infected from these rodents? People get infected after exposure to aerosolized excreta, urine, and saliva of infected rodents. Sometimes it has been documented that infected urine or excreta can directly be introduced into broken skin and mucous membranes of the eyes, nose, or mouth. Those who work with live rodents, as in animal houses, they are always at the risk of getting bitten by infected animals. Human-to-human transmission is very rare, and only one case has been documented from South America in 1998. Generally, we believe that humans are dead-end hosts of hantaviruses. Hence, it is very difficult for human-to-human transmission to take place. This slide gives an idea of the distribution of hantavirus serotypes in different parts of the world. The old world hantavirus serotypes are larger in numbers and can be seen in different parts of Europe and Asia. There is only a single serotype that has been described from Africa, Sengausu serotype, but we are not very sure whether it can cause clinical disease. There are a large number of hantavirus serotypes described from the Americas. Most of them cause severe hantavirus cardiopulmonary syndrome. The distribution of the rodent or mammal hosts of these hantavirus serotypes have the same distribution. Fever with renal syndrome. The incubation period is about 1 to 2 weeks. Very rare case, it takes up to 5 weeks. Onset is with fever and influenza-like symptoms. Rarely, patients show hemorrhagic manifestations. Theoretically, this clinical syndrome has been divided into 5 phases. There's a febrile phase which lasts about 3 to 5 days, followed by a hypotensive or a shock phase, which lasts from a few hours to a few days, but 1/3 of HFRS related deaths occur during this hypotensive phase. It is followed by an oliguric phase lasting 3 to 7 days. Half of the fatalities reported occur during this phase. It is followed by a diuretic phase and then a convalescent phase. Complete recovery can take weeks to months. As I have mentioned in my earlier slide, severity varies with species. Hanta virus and Dubrava virus cause severe HFRS, whereas Sol virus, Thailand virus, Pumala virus cause mild to moderate HFRS. Hanta virus cardiopulmonary syndrome caused by hantavirus serotypes circulating in the Americas. The early symptoms of HCPS are very non-specific, similar to those seen during HFRS. But 4 to 10 days after the initial phase of illness, late symptoms include the respiratory system, and most deaths, they occur due to cardiac failure rather than pulmonary edema. Laboratory diagnosis of hantavirus infections. Serology remains the mainstay of lab diagnosis of hantavirus infections. There are plenty of ELISAs available which detect IgM and IgG antibodies. They are moderately sensitive and specific. They employ N antigens. These N antigens can be native proteins, they can be recombinant N antigens, they can be whole N antigens or truncated N antigens. N antigens are used because there is a great deal of cross-reactivity of the N antigens between these hantavirus serotypes. And as you know, ELISAs have a lower cost. The disadvantage of ELISAs are they become positive later than PCR or molecular methods. They also cannot be used for serotyping. Another method commonly used in many laboratories for lab diagnosis of hantavirus infections is indirect immunofluorescent assay. This test employs native proteins or N antigens as in ELISA. IFA is much more sensitive than ELISA, but it has a low sensitivity. It is more laborious, it requires specialized equipment and not very commonly used. Western blot, as we all know, it is much more sensitive and specific than ELISA, but it is expensive and used only in some special laboratories. If you need to do serotyping of hantaviruses, you need to use neutralization tests or focus reduction neutralization tests called FRNT. Remember, for neutralization test, you need to use the whole virus, live virus. So this test can be done only in a BSL level 3 laboratory. Many laboratories have now switched from serological testing to molecular testing, and they use polymerase chain reaction in different forms, the conventional form or the real-time RT-PCR form. Molecular methods are rapid, they have a higher sensitivity and specificity compared to serological methods. Of course, they are expensive, they need specialized equipment, trained personnel, and the period of detection is very narrow. That is, only up to the first week after the onset of the illness, you can detect the hantavirus RNA. Other methods that I would like to mention here is the virus culture. Now, unlike many viruses which grow beautifully in cell lines, hantaviruses have very few cell lines in which they can be cultivated. For example, one of them is Viro E6 cell line. But again, this is a very slow method of lab diagnosis. It has very low sensitivity. It's expensive and it can be done only in a BSL level 3 laboratory. Currently, there are about more than 100 hantavirus serotypes. And here I've tried to give a very concise understanding of the kind of phylogenetic relatedness between these different hantavirus serotypes. Now, this phylogenetic tree is based on the S segment, but even if you use the M or the L segment, you see similar kind of evolutionary branching. So based on the S segment, we now see that there are three important clades of hantaviruses. One is the Hantan virus clade, which includes Hantan virus, Sol virus, and Dubrava virus. Now, these serotypes circulate in Asia and Europe. Then we have another clade which is called the Pumala virus clade. Now, this clade includes those hantavirus serotypes that are carried by rodents of the family Arvicolinae. The third clade is the Sin Nombre virus-like clade. That includes hantavirus serotypes which are carried by rodents of the family Sigmodontinae. You can see a small circle away from this phylogenetic tree, which is the Totapallium virus. Now, Totapallium virus was first described from India, to be more specific, from Vellore in Tamil Nadu in 1968. Now, earlier it was thought to be an arbovirus, but later on found that it was very similar to hantaviruses and they all share a common ancestor. It is highly divergent, both antigenically and genetically. That is why it is placed away from the phylogenetic tree. Currently, no known antiviral drug is available for treatment of hantavirus cases. Ribavirin has been used in China to treat severe HFRS cases, that too early on after onset. We know ribavirin inhibits viral replication. In severe HFRS cases, if used early, it results in lower virus titers, lower morbidity, and higher survival rates. But ribavirin has not been very effective in treating HCPS cases in the Americas. So the only option is supportive therapy with careful fluid management, electrolyte balance, and hemodynamic monitoring. Vaccines. It's strange that even after 70 years after the first case of hantavirus disease was described, we still do not have licensed vaccines which can be used globally against hantavirus disease. Of course, this could be because the different serotypes that circulate all around the world are quite genetically different, antigenically different. So what has been seen is that different countries use their own vaccines manufactured locally just to reduce the disease burden. For example, Korea, they use a HFRS vaccine, Hantavax, which is actually an inactivated vaccine. Similarly, China, which used to have a high burden of severe HFRS cases, has been using a bivalent inactivated vaccine containing Hanta virus and Sol virus virions. There are DNA vaccines and subunit vaccines and virus-like proteins which have been in the pipeline, but none of them are licensed to be used right now. How do you control and prevent hantavirus infections? The best way to avoid infection is to prevent exposure. For example, in case there are human dwellings which have signs of rodent activity, they should be completely decontaminated. Rodents, keeping them as pets is a complete no-no. Proper storage of food so that rodents do not invade dwellings. In case closed spaces need to be cleaned, closed spaces which have evidence of rodent activity, then use adequate precautions and proper PPE. Just to take you through research studies that have been done in India on hantavirus disease and circulating hantavirus serotypes. Now, the study that I mentioned, this was funded by ICMR and was done at the Department of Clinical Virology, Christian Medical College, Fellow. Just to mention here, in 1968, a hantavirus isolate was reported from an insectivore which was captured in Vellore. It was named the Totapalayam virus, TPMV. I have mentioned this virus in one of my previous slides. Initially, it was thought to be an arbovirus, but later genetically proved to be a hantavirus serotype. I'll take you through the next few slides and highlight important sub-studies which we have done to prove circulation of hantaviruses in India. In this study, we recruited 499 patients with acute febrile illness. All these patients were negative for dengue, leptospirosis, and scrub typhus. Samples were collected from patients. Serum samples were tested for IgM and IgG by ELISA and IFA. Serum samples were also tested by an in-house RT-PCR that employed a partial S genome segment. 5.2% of the samples showed serological evidence of hantavirus infections, whereas 2.3% of the samples showed molecular evidence of hantavirus infections. We were able to generate a very simple phylogenetic tree, and it was seen that the nucleotide identity of the patient sequences had a 84 to 98.5% homology with Hantan virus and 71.7% to 61% homology with Thailand virus. It was very divergent from TPNV sequences. This slide indicates details of a seroprevalence study which we did to establish hantavirus infections in India. The seroprevalence study used healthy blood donors as the control group. Risk groups included a tribe called the Irulas. These urulars catch rats for farmers and they eat the rats. Second group were patients with chronic renal disease, and third, go down workers. The testing systems that we used included IFA, employing Hanta virus antigens, and Western blot strips which were impregnated with the N proteins of Hanta virus. The blood donor group showed low seroprevalence of 4%. Among the risk groups, urulars displayed a very high seropositivity compared to the blood donor group, which was statistically significant. We tried to do serotyping of the hantaviruses circulating in India using serum samples that were positive for hantavirus IgG. Serotyping was done at the laboratory of our collaborator at Hokkaido University, Japan. The results indicated that there was a Thailand virus-like, a Hanta virus-like, and an unknown serotype circulating in India. The results clearly showed that there are more than one novel hantavirus species in India. Our study on hantavirus infections in India would have been incomplete but for the animal studies that we did. We were able to capture 83 rodents, including bandicoots, black rats, and a single insectivore. We collected lung and kidney tissue of these captured animals. Testing systems included IFA, employing Hanta virus antigen. Western blot strips were impregnated with the Thailand virus antigen. RT-PCR that we had used for human samples were used to test the lung and kidney tissue of these captured mammals. 19.3% of the animals showed reactivity in IFA. Only 9 of those were confirmed by Western blot. One single animal was positive by RT-PCR. What was the takeaway message of our research? 1. Hantaviruses do circulate and cause disease in India. They are very similar to Asian serotypes like Hanta virus and Thailand virus. Most of them are hosted by bandicoots. It is very important to consider hantavirus infections in the differential diagnosis of acute febrile illness, along with scrub typhus, leptospirosis, malaria, dengue, and other causes of acute differentiated fevers. Coming back to the original question, is a hantavirus pandemic possible? The answer is no. Because unlike SARS coronavirus 2, the etiological agent of COVID-19, human-to-human transmission of hantaviruses has not been reported. A very rare exception to this has been the report from South America of human-to-human transmission that was reported way back in 1998. So like I mentioned earlier, the life cycle of hantaviruses completes itself only in rodents, while humans are dead-end hosts. Thank you for your patient listening. I'd be happy to take questions.